Hello, hi guys. So unfortunately you've just got me. I'm Louise and I'm one of the F1s. I'm on orthopaedics at the moment. Dave hopefully should be joining us shortly. He's over at St James's, so he's probably got stuck in a bit of traffic. But today we're going to go over some neurology for finals, and it's specifically aimed towards your OSCEs. So kind of things we're going to cover today are we're going to look at some neuro OSCE stations, and we kind of hope that now you've got here to 5th year, it's easy for you guys. You should be able to do a PNS and CNS with your eyes closed, going backwards. So there's no point in us covering that. We're going to look a bit more specifically and get you to adapt your knowledge that you've had from 3rd and 4th year and try and apply it to a kind of scenario. And then we're going to give you some feedback. So yes, we are going to be after some volunteers from the audience, a bit of audience participation, and then we can talk about kind of the theory. So it's one thing in an OSCE talking about saying you'll elicit this and you'll look for this sign, but you need to know why you're looking for that. And then we'll go over some common neurological diseases. So there's quite a few patients who are stable, who have neurological symptoms that they can get in for OSCEs. So we're just going to touch on a few of them, not literally, but touch on a few of those kind of subjects and just dance around those so you can get a bit of an idea of what to have if you're into an OSCE. And then we've also just thought we'd give you a bit about practical neurology as an F1. You never get asked by a consultant to say, oh, go and do a neurology exam on this patient, so we're just going to show you some examples of when we had to go and do it, and when you think about going to do it. And then we'll also go over some previous OSCE stations that have come up over the last few years at Leeds. And then we've got some examples for the slideshow, which I think you always feel like you can never have enough practice of that, so we've got some of those for you to go through. And then also at the end we've got some reference slides, so there's no point in us just talking off slides for you. You can do that in your own time and just read them, so we've got some of those at the end which we feel might be useful for PNS and CNS exams. So can we have a volunteer, please? I'm going to have to pick someone. There's a prize, edible. If that makes it any more. No?
I'll do it, but I don't know anything.
That's fine, okay. No, step forward. Sorry, what's your name?
Helen.
Helen. Okay, right then. So you can ask for help from the audience if you feel like you need it. But unfortunately, I'm going to have to be the patient here, as Dave's not here yet. So we'll set the scene for you. So it's finals, they've finally come around, and you're outside your first OSCE station, and you read on the door, in your frantic 1 minute, this 55-year-old gentleman has presented to the GP with trouble walking. Please perform a focused neurological examination. So, as with examinations, it will be 8 minutes. So we'll go for 7 minutes. So I want you to focus and then present your findings. Okay. Can I have someone start a stopwatch for 7 minutes and then shout out when 7 minutes is up? That's
yeah,
Rob.
can do.
Right. Okay. So I'm a 55-year-old gentleman, and if you get stuck at any point, then you can ask. I'll just get into character. Okay.
Okay.
Yeah.
Hi, I'm Helen. I'm one of the final year medical students. Can I just get your name and your date of birth for you?
My name is Harold. I am 55.
Okay, well, it's nice to meet you, Harold. I've been asked by the doctors if I could just do a quick examination on you. It would probably involve looking at the power and stuff in your lower legs. Is that okay with you?
Yes.
Okay. Can I just ask if you could just lay back on the bed? So I give you a hand there.
Thank you.
There we go. Right. Okay. So first of all, looking at the toxic example, looking at the patient, I can see that he's got quite a masked face appearance, and he's got some pin rolling habits in his hand as well. Okay. So first, well, I do the ask you to walk. But first of all, can I just ask you if you could just move your leg up, lift the leg up off the bed for me, and back down again for me, and this one as well. Is that as much as you can lift it up?
Yes.
Okay. And if you just do that again and stop me from lifting it, that's fine. And this one as well. Okay. And can you push out for me? Push out. Okay. So power seems to be, if we lift up from here, push against me, and push down as well. And down. Power seems to be all very intact and fine. I'm just going to test your reflexes as well. I ideally have a reflex hammer for this. If I could just ask you to lift it up like that. Okay. So that's fine. You see that works fine. And this one as well. That's absolutely fine. Okay. I'm just going to have a look at the bottom of your feet as well. So I'll do, while I'm doing this, I'm doing general examination to see that there's no muscle articulations or any wasting of the legs at all. I'm just going to see that there's good reflexes there. If you could just down, see that the toes are absolutely fine there as well. If you just put your ankle over your leg, bend your knee. Perfect. And then I'm just going to tap here. See, that's fine. And this one as well. See, that's absolutely fine. Okay, we'll put that back. Looking at the heels, I can't see that there's under the feet. Can't see that there's any ulcers or pain there, problems there. Okay, so just going to test the sensation as well. Ideally, I'd have a sharp grace sensation thing. So, can you just tell me whether this feels the same on both sides or not? Yeah. Can you shut your eyes for me? Tell me what leg it is.
Left. Right.
And that feels the same on both sides?
Yeah.
So L1, L2. What's that one?
Left. Right.
Still the same on both sides?
Yes.
L3. Can you feel that?
Yes.
Feel that?
Yes.
Okay. So L4 and what's that?
Yes. Yes.
4 down here.
Yes.
5.
Yeah.
And the feet as well? Okay, that's fine. Okay.
I'll get started.
Okay, can I just feel, I'm going to feel for tone in general, so I'm just going to move around. It's quite a stiff tone. And I'm just going to have a quick look at your arms as well. So if you just relax for me. Okay, so it's quite stiff, some cog wiggling a little bit there. And relax a little bit for me. And they're exactly the same on that hand as well. Could you just relax your shoulders? And again, it's all very stiff. I'm rigid. Okay, could you just grab my fingers for me? Stop me from pushing you. And push me away. Oh, sorry, there we go. And the other way around. Yep, that's it. And grip my fingers as hard as possible. Okay, so there's good power there in all of the arms. We see some fidgeting, as I said, and some cog wheeling stiffness as well. Just going to test your reflexes. Just relax your arm. That's fine. And relax it against mine. That's fine. This side as well. So just relax it against mine. That's fine. Okay. That's fine. Okay. Can I just ask you quickly to pull your leg round again for me? Just going to ask you to do some walking. Okay, so can you jump off the bed for me? Oh, there we go. Can you just walk towards me, please? So I can see you shuffling gait, quite pleasant. Turn around for me. So very typical gait of someone with Parkinson's disease. If you walk towards me for me. Hesitant and starting off and then shuffling forward. Okay. That's fine, thank you, sir.
Hey, no, another minute and a half in.
I like you going, yeah. If you want to quit, just say, has anyone got anything else they want to add to this examination?
Reflexes,
I
do sensations.
Let's think about it's a
I know what
focused neurological examination.
Someone that's having trouble walking. I would have also tested, I can get you to lie down again to be able to do this, but I'll do the movement in the legs as well, and tapping, and I could do that with baby limbs as well. So do that with power, tone, reflexes, sensation.
Well done. Give you a prize. Okay. So Helen, come back and now choose. Wish you volunteered now, don't you?
I'll probably go through it. Thank you.
Okay, so well done. That was a bit mean on the spot. Just before we go any further, this is Dave, by the way.
So I'm late.
So we thought we'd give this OSCE station a bit of a bash for you guys, because it's something we got quite similar. Ours was, I don't know if I'm sure you've heard the woes and tales of our OSCE from last year, and we got given a video with someone with Parkinson's, and we got asked about all the different various signs. It was like trying to drag back a horrible nightmare from third year. Nobody could remember it at all, and it's something that they could definitely put in. Parkinson's patients are really, really stable, and they've got great signs. So you did really well, and you've got some really good features of Parkinson's. There's a few more that we'll just go over, but when we're taking a focus, there's certain things that you probably didn't really need to bother with in that, sensation and reflexes. They're not really that focused towards being Parkinson's. But so I kind of gave the answer away there, Parkinson's, but I think you got it anyway.
Before you go any further, if you finished a bit early, it's always good to do a summary because it just makes you look really professional and you get extra marks for it. And then the examiner's left feeling like you know what you're doing if you say, oh, so this is somebody who's presented today for the purpose of examination. And then just go through what you found. And it'll also remind you of things that you haven't covered.
So quickly, before we just kind of recap and talk about certain things you look for in Parkinson's, does anyone know any different kind of drugs that can cause Parkinson's or Parkinsonism?
Antipsychotic.
Yeah, very good. What type of antipsychotics? Yeah. Any others?
Micrograph.
Very good.
Very good. Who said that?
Savage knowledge.
That's really good.
Anything else? Any other common medications that we see? So someone said antipsychotics and metoclopramide. Also things like lithium and haloperidol as well. That's quite a common drug that you see the elderly come in on until some of the elderly wards. So just to kind of run through kind of the basic parts of Parkinson's. So it was characterised classically by this triad of arresting tremor, bradykinesia, I'm not sure if you got the gist that I was trying to move quite slowly, and rigidity. So looking at the face, so like Helen identified, I had a mask-like face and it was expressionless. They don't blink very often, and they also have something called the glabella tap. Does anyone know, or if you perform the glabella tap, what that is? Someone's pointing on a forehead.
When you tap their forehead and they keep blinking.
Yeah, very good. So you can try it on one of your friends or just try it yourself. So if you tap one of your friends on the forehead, they'll blink for the first few times and then they adjust and they stop blinking. But with someone with Parkinson's, they'll continue to blink when you tap them in the forehead. If you do it on yourself, it doesn't quite work the same, but never mind. 10 out of 10 for trying on that one. And then gait, so they have a flexed posture, reduced arm swing in their gait, and Helen really described it really, really well. It's fast and it's slow to initiate and stop movement, and they take a long time to kind of turn. Their toes increased, they get cogwheeling and lead pipe rigidity. It's great if you can spin off some of these like catchphrases during your OSCE. The examiners absolutely love it. Something that we got in our OSCE station, they showed us a video of this doctor assessing a patient with Parkinson's, and he was getting him to tap his thigh whilst he was assessing the cogwheeling. I don't think anybody knew that apparently brings out cogwheeling more. But there's a little nugget of information for you guys, so we don't know, so we're passing it on. And yeah, hill rolling, so that's really, really common. And also speech, it's really slow, hesitant, quite monotonous. And they also have micrograph here, which I'm sure you remember. So you could always say to the examiner, look really smart and say, I'd like to get a pen and paper and get this patient just to write a quick sentence for me, and just have a look at their handwriting. We did have a really, really jazzy video to show you how it's done, but A, it doesn't work, and Helen did a great job, so we don't need to show you how it's done. So moving on to OSCE Station number 2.
Okay, so OSCE Station 2, we need another volunteer, please.
I'm going to have to bully someone.
Excellent, Martin Webster, you're up.
So I had a sweet question on the first one.
Yeah.
Do you, so obviously because it's a focused examination of trouble walking,
Yeah.
so do you have to bring out all the possible tests you have for Parkinson's disease rather than just doing like a focused lower limb?
I think you'd be really unlucky to get a station like this.
Right.
Like I'm sure Chesh explained, we didn't want to give you like a standard cranial nerve exam. I think it'll be a lot more straightforward in your lead spine, but like the patients, when one of Chesh's friends had this as their OSCE station, it was very obvious this patient had Parkinson's disease.
Okay.
And the fact that it doesn't say perform like a cranial nerve exam or a peripheral nerve exam, it's like a focal neurological exam. Like I think people were supposed to kind of get that it was Parkinson's.
Okay, right.
And just, we're not trying to be mean, like this genuinely came up in Manchester as an OSCE, the same scenario, so it's not out of the realms of possibility. I think Leeds are a lot nicer, but we just wanted to push you a little bit further and try and make you think outside the box a bit, because essentially to get the high marks, that's what you have to do at OSCE.
If you like panicked and had one of those moments where you just literally went off on a tangent, would they kind of say to you, do you want to read the thing again? Like if you were doing something that were a bit like they're never going to get in 8 minutes.
Depends on your examiner. Depends on your examiner. If your examiner's nice, they might do. I had a really nice examiner, an orthopaedic surgeon in Bradford, who literally sat there and was just like, right, let's tick these boxes. What else? Look at this. Look at this. What's he going to do? What's he doing now? And some people just said nothing. So honestly, it really depends on your examiner. But if you panic, just don't panic. It's the worst thing you can do in finals. All right. Oh, I'm the patient. I'll time check.
Okay. Okay, so again, shout out from the audience if you feel like he's missing something greatly obvious. This is a history station. We just thought we'd mix it up a bit because obviously you're going to get histories as well, and I'm sure we've had a lecture about this topic, but we just thought we'd touch on it anyway. So, again, it's come round to finals and you're outside your OSCE station, and this is the second one now. You asked to see Gladys, who's a 75-year-old wonderful lady who's presented to A&E with a history of difficulty speaking. Please take a focused history. The examiner will stop you after 7 minutes for questions. And some nurse has been really, really kind and triaged the patient for you, and they've got some basic obs there. So BP 160 over 95, heart rate 90, rest rate 17, O2, SATs, and 97% on room air. And they've got a past medical history of COPD, hypertension, and diabetes. Are you ready?
Go.
Hi there guys, I'm Martin, I'm a fifth year medical student. Is it alright if I ask you a few questions about why you're coming today?
Oh yes, that's fine.
Okay, can you just explain in your own words what's been happening?
Oh yes, well, it was about 3 o'clock this afternoon, and I noticed that suddenly I couldn't really move my left arm.
Okay.
And then my son noticed that I wasn't talking right.
Okay, can you describe how you were talking?
Like that.
And what's happening with your left arm? Did you have no power in it, or
No what?
could you not move it? Did it feel heavy?
I couldn't really lift it very well.
Okay. And have you noticed any other problems by your speech or your arm?
No, I haven't. No.
Okay. And you said this happened at 3 o'clock.
Yeah.
Okay. Have you had any recent falls or recent trauma or anything like that?
Trauma, doctor, no. I haven't fallen, no.
Never fallen, okay. And have you had any problems with your walking or anything like that?
Well, I don't walk very quickly anymore, doctor, because I'm 75.
Yeah. Did you have any problems with your vision or anything?
What, today?
Mm-hmm.
Not today, doctor, no.
When you say your arm's heavy, has it been, have you still got sensation on it? Can you still feel it if I touch you?
I think so. It seems to be better now.
It seems to be better now, okay. So your arm's better now and your speech seems better now?
Yeah.
And this happened at 3 o'clock today?
Yeah.
Okay. And have you ever been admitted for anything to hospital before?
Only when I had my kids, doctor.
Okay, excellent. Do you see a GP for anything?
Yes, for my breathing and my blood pressure and my sugar.
Yeah, okay. And you got any allergies to anything?
I'm allergic to penicillin.
Okay, and what medications are you on?
I'm on medications for my blood pressure and my breathing and my sugar.
And have you got any family history of any cardiovascular diseases?
Any what?
Any problems with your heart? So anything like high cholesterol, diabetes?
No, I'm the only one with
attacks,
diabetes.
strokes?
No, I don't think anybody, not that I know of.
Okay. And have you had any chest pain recently?
No, I haven't.
Lost any weight?
No, I've not lost any weight.
Have you had any more going to urinate more often, or have you burning when you have been going?
No, I don't
Been
think
a
so.
change in bowel habit?
No.
And have you had any fits, faints, or funny turns?
Well, I had this funny turn today, yeah, but apart from that, no, not really. Occasionally I feel my heart going a bit, you know.
Okay. So when you say you feel your heart going up a bit, what do you mean by that?
Well, it just seems to just goes into this weird, like it's beating out my chest, and it doesn't seem to be very regular.
Okay, you ever mentioned that to anyone?
Just you, Doctor.
Just me.
Now that you asked me so detailedly.
Okay. And could you tap out how it goes?
Yes, I could.
Do you want any help from the audience?
Yes.
No?
Smoking, drinking.
Yeah, that's social recreational. Do you smoke at all?
No, I don't.
Do you drink at all?
No, I don't.
And what was your previous occupation?
I was a doctor's secretary. Do you want to ask me any more about what happened at the time of my...
You had difficulty speaking.
I did have difficulty speaking.
Was
Yeah.
it difficulty in producing the words or finding the words to say?
I just sound a bit drunk. That's what my son said. I was like,
Do you have full memory of everything that went on?
yes, I do. I didn't pass out at all.
Are you right or left-handed?
I am right-handed.
And which side did it affect again?
It's affecting my left side.
Any problems with your vision?
Not today, like I said.
Have you had previous problems with your vision?
I have had a previous problem with my vision. About a couple of weeks ago, I felt like there was some curtains or something coming in across my eyes.
Did you fall to the ground?
Yes. No, I don't think I did. Maybe when I tried to get up from my chair, I stumbled a little bit, but I didn't fall.
So you didn't hit anywhere?
No, I don't think so.
What did your son say happened?
He just said I just kind of got this funny look on my face, and then half my face dropped, and then he went to ask if I was all right, and I couldn't speak properly, and then I couldn't lift my arm.
Are you back to normal now?
I am back to normal now.
How long did it take before you back to
It
normal?
lasted 55 minutes.
Is that it? Any differentials? Shall we go for?
Yeah? You have happy? Do you want to do a little summary for us, Martin?
Yeah. We have Gladys, 75-year-old lady who suffered problems speaking and describes left arm weakness. She has a history of several cardiovascular problems like hypertension, diabetes, which she's currently having medication for. She has an allergy to penicillin, and there's no family history of any stroke or cardiovascular problems. A differential would be TIA, because it's lasted less than 24 hours, maybe MS, or some sort of peripheral neuropathy, but it's only minor.
Okay.
Excellent.
Yeah.
Very good. Did everyone hear that? All of the differentials? Yeah, so TIA, peripheral neuropathy, MS. I think everyone else would have had those as the main ones. So we've got some questions. Do you want to collect your prize?
Well done, Martin. Just before we move on, would anybody have asked anything else about the event itself? This is a lady who's presenting with an acute neurological problem. Is there anything else you want to ask about, like the event, what happened when it came on? Very good, very good. Any incontinence? Very good. Any tongue biting, stuff like that. Although apparently that's actually quite a weak sign for epilepsy, but so yeah, you want to exclude all the big names in neurology, and don't, even though it is a barn door TIA, don't just assume it's a barn door TIA. The examiners want to see that you can exclude other common neurological problems. Okay? So that's what I'd say. But apart from that, well done, Martin.
Okay. Some questions?
Yeah, I was thinking it was a barn dog TIA, and I just couldn't get that in my head.
Yeah, that's fine. That's fine. But in finals, they want to. That's kind of a third year mindset. In finals, they want to make sure you're thinking about other things it could be and excluding the red flags, problems like that. Okay. So, what scoring systems are available for assessing the risk of stroke after TIA? Somebody said it.
ABCD2.
ABCD2. Yeah, very good. So what's the ABCD2? What is A for?
Age.
And what's the age? 60, isn't it?
60, yeah. We've got it on another slide. B.
Blood pressure.
Yeah. What's the blood pressure parameters? Yep. So systolic greater than 140, blood pressure diastolic less than 90. C.
Clinical symptoms.
Yeah. So what's the scoring? This is the difficult bit. What's the scoring system for clinical symptoms?
Unilateral weakness.
How much does unilateral weakness score?
2.
Very good. And how much does speech disturbance only score? Good. And what's D?
Duration.
Yeah. Duration.
Less than 10 minutes to less than 55.
Almost.
Greater than
10 to 59 minutes, and then over an hour, 72.
And then what's the other D for? And how many does that score you? So what's the total ABCD2 score out of? 7. It's out of 7. So what's this lady's score? Chess, do you want to go back to?
Yeah.
Be bold.
7.
It's not 7. It is 6. Okay, so she scores 1 for being old. She scores 1 for her systolic. She scores 2 for her clinical signs. She scores 1 for diabetes and 1 for duration. Okay, so that's 6. So what's your... oh, sorry, Chesh. So next question.
Okay. What's your management plan for this lady? What would you do?
If she's not in A&E, you can send her straight to A&E with a 4 or more.
Yeah, good. So if she was in A&E, what would you think about doing? CT going to be the very first thing you do? It's going to be up there.
ECGs though, yeah.
Okay. Anything else we'd do before? Anything else we'd do before? What's finals all about? Very good. ABCD. So you just always say that. So good. We'd do bloods. What bloods are we going to do?
FDCs, users.
Yep.
LFTs.
Why are you going to do LFTs?
I have no idea.
Right. Don't say it then.
Clotting.
Clotting. Very good. Anything else?
Thyroid.
Yeah. Yeah. Something more common, given her past medical history. Glucose, good. What's the other one?
Lipids.
Lipids, maybe do a lipid profile.
ECG, very relevant.
Yeah, ECG, very good. So Martin, you just about got that. I was having funny heartbeats. And then, yeah, so she needs a CT, pretty sharpish. And then
Carotid Doppler.
Yeah. Anyone know the cut-off for when we send them to vascular surgeons? 70% occlusion. Or 75. It's one of the two.
And the last thing to consider is things like lifestyle factors. So we're looking at antihypertensives. We ought to bring down that blood pressure of 160 systolic. So you'd want to be doing that acutely. I'm both thinking in the long term if that's a continual blood pressure that she has for her. And also antithrombotics as well, with her having AF. So you want to think about commencing her on warfarin or something like that. Excellent, well done. Oh, last question.
Yeah, just a small point. Does anybody know what the guidance is on driving after a TIA?
1 month.
Very good.
Multiple then.
Good.
Better than we
Yeah.
Great, well done. So that's just a little summary slide. Well done, you all knew it, so we won't spend
Did you say it's 1 month or 1 episode and 3 months for more?
Yeah,
Yeah.
I only knew it was 1 month if you had a TIA, but apparently it's 3 months if you have more than one.
Okay, so moving on to cover kind of common neurological diseases. We've already touched on Parkinson's and stroke. We feel they're kind of like the main biggies that you could be assessed on. MS and peripheral neuropathies, so for example, when patients have diabetes and things about how they can present, we felt that these patients are quite stable. They could easily come up at an OSCE. I don't think MS has previously come up. Things similar to peripheral neuropathy have in the past, so we'll just quickly go over them for you. Things like Horner's and facial nerve palsy, definitely be aware of them and have a bit of knowledge for things more like the slideshow and maybe the odd EMQ and MCQ, but it's really, really unlikely you have anything like that in the OSCE.
Okay, so I'm going to talk a little bit about MS. Like Chesh said, these are quite stable patients. So although they haven't done it before, it'd be quite easy for them to bring in a patient with clinical signs of MS or an MS history. Okay, unlikely, but it's good to be aware of it. Has everybody heard of MS? So it's for multiple sclerosis. Anybody know the definition of MS? Or how it's diagnosed? What are the... That's good, she knows. She knows what you're saying.
You have to have two episodes separated by time in a different region.
Yeah.
McDonald criteria.
The what, sorry? McDonald criteria. Very good knowledge, very good knowledge. So you need 2 more episodes of central nervous system lesions disseminated in time and space. Anybody know how MS patients commonly present? Optic neuritis. So what will a patient say to you? It's me eyes, doc. Yeah, very good. See you at sequential testing. Anything else they'd say? Anybody know what people with optic neuritis complain of?
Blurred vision, loss of acuity.
Yep, blurred vision, loss of acuity. They can sometimes describe it as being like shattered glass. Very good. So, optic neuropathy. What else might they get? Transverse myelitis, yep. So, looking for a spinal cord lesion. And the final thing is you get brainstem demyelination as well. So, asking about things like diplopia, vertigo, dysarthria, and dysphagia. Okay, but most commonly, and in most kind of finals exams, it'll be like a 30-year-old woman, this is mainly for the MCQ, who presents with weird neurology. And she had a similar episode last month. In fact, I think that was a question and ours, wasn't it? Yeah. Okay, so it will be straightforward. So here's a great example of blurred vision for the chap up there who said it's in the eyes, doc. In terms of investigations for MS, does anybody know what first-line investigation for MS is? MRI. It is an MRI. It's one of those weird ones where like the first thing you do is get them an MRI. And does anybody know, this is for real bonus points, anybody know what you tend to see on MRI, where you tend to get plaques of demyelination? The where? Yeah, where in particular? In the head, yeah, good Helen, yeah.
Next, it's like, I can't quite, no, I can't pinpoint where it is, but I can see it on it. Super
Brilliant. The what, sorry? Somebody nearly said it. Is it periventricular? Is that what you're saying? Yeah, so periventricular white matter. Okay, this is a bit of a barn door example. So this is what you're looking for. Also in the spinal cord, particularly the C-spine, you tend to get plaques of demyelination. So if you look on they usually give you a coronal section, you can see the plaques of demyelination. All right. And interestingly, with MS, well, I say interestingly, I find it interesting. The clinical picture is often not at all related to what you see on MRI. So they can have widespread demyelination but still have quite a good level of function. And equally, they can have very little evidence of demyelination, but quite severe function deficit. Okay.
Cool. So moving on to polyneuropathy, also known as peripheral neuropathy. So this is really, really common in diabetics. Again, these patients are really stable, so great for the examiners to get in for OSCEs. They generally have bilateral, gradual and symmetrical tingling, numbness and burning. I'm sure you'll all be familiar with the glove and stocking kind of distribution, which is shown by this lovely grey and white diagram here. They often present with loss of tendon reflexes in the lower limb and Charcot's joint. Can anyone tell me what this is? Someone say destruction.
Careful saying rocker bottom feet, that tends to be Edwards.
Some kind of congenital disorder with rocker bottom.
You could be right. I think that's generally the description for one of those congenital syndromes.
So destruction of the bones, but why do they get destruction of their...
You lose these foot arch because of neuropathy, and then therefore you get the bone destruction.
Yeah, so basically they're not able to feel, they've got really, really reduced sensation in their feet. They can't feel what they're bashing into or how much weight they're putting onto it. And so they just get really, really bad degeneration, normally bilaterally in their ankles, and it gives them really, really bad joints in their feet. So some common causes of polyneuropathy. Thankfully this fits into a really nice algorithm like everything else, A, B, C, D. So you can see alcohol, B12 deficiency, carcinoma, chronic renal failure, and the most common one that you're going to get in your OSCE is something like diabetes. If you want to be really smart, things like Guillain-Barré, hepatic failure, infection, and Charcot-Marie Tooth syndrome. Don't get hung up on all these eponymous syndromes, but you know they're quite interesting, some of them, but they're good to know just for things like slideshow. Apart from that, they probably won't come up.
Does thyroid as well?
Say again, sorry.
Does thyroid problem?
Quite possibly. Thyroid tends to cause a lot of stuff. I don't know.
Yeah, I wouldn't put it out there.
Like your big ones that you're going to get in league finals are like alcohol and diabetes. Okay, so we thought, whilst it's all very useful us telling you about, you know, passing your OSCE in terms of neurology, it is actually quite relevant when you go onto the wards next year, which is only, what are we, February, March, April, May, June, July, 6 months away. Very good. So we wanted to just think about, because when you're on the wards, you don't get somebody saying, oh, we've got a lady, can you just go and perform a cranial nerve examination on her? You get a lady who comes in with a presenting complaint, and you have to decide what you're going to, what examination you're going to do. So somebody want to shout out some presenting complaints or some reasons why you'd want to do a cranial nerve examination or a peripheral nerve examination on somebody?
Recurrent falls.
Falls, yeah. So any trauma?
Head injury.
Yeah, head injury.
Weakness.
Weakness, yeah.
Swallowing problems.
Swallowing problems, good.
Speech.
Speech disturbance, very good.
Meningism.
Yes.
Swallow.
Swallow, yeah.
Loss of bladder and bowel function.
Yeah, good.
Abnormal sensation.
Yep, abnormal sensation. What about in a common things you see in hospitals? So you call see an inpatient. What do lots of people have in this country?
DVT.
Maybe not.
What about like neuropathy pulses?
Yeah. I mean, it's getting to like pretty small print stuff. Thinking like post-ictal, somebody's had a fit. Like you want to be thinking about doing an examination. Somebody's got a headache, like a really bad headache.
Things like reduced GCS, so you're called to see a patient, their GCS has dropped 30, you definitely want to do a quick neuro exam on that patient.
Okay, so I was called, I'm on surgery at the moment, and I got bleeped to go and see a 35-year-old lady with newly diagnosed palliative cholangiocarcinoma, complaining of sudden onset of the worst headache ever. The heart rate was 140, blood pressure was 130/90, respiratory rate was 35, and she was screaming out, help me. So, what are you going to do?
ABC.
Good, ABC, pretty happy A is alright. B, what do we think about respiratory rate? Pretty fast. C, she's pretty tachycardic. It doesn't get much above 140 before you're actually compromising your output. Okay? So what are your differentials for this lady? Subarachnoid, yeah. So if you think somebody's had a subarachnoid, do you think you need to do a cranial nerve exam? Good, and probably a peripheral nerve exam as well. Alright. So I went to see this lady, and I obviously did ABC, did an ECG on her, and she had a just supraventricular tachycardia. I looked back in the notes, and she'd been newly diagnosed with palliative cholangiocarcinoma and was really struggling to come to terms with the diagnosis and had been suffering from panic attacks. And this is what this was. She was having a panic attack, but obviously you can't just assume it's a panic attack when you go to see her straight away. You have to do a cranial nerve examination to rule out anything sinister. Okay. Very good.
Okay, so as you can see, it's really common. I've also got experience. So I was on MAU and I was asked to see a 21-year-old chap with acute onset dizziness, nausea, and just generally feeling a bit off it, not very well. So I did a neuro exam, but can any of you, have you got any differentials? Yeah? Munez, yeah? Say again?
Drugs.
Yeah? Yeah, very good.
Sepsis.
Yeah, it could be, beginning kind of stage of sepsis. Say again?
Postural vertigo.
Yeah, very good. Yeah. Yeah. Okay, so very good. You all got it. We did a neuro exam and he had the most outrageous nystagmus I think I've ever seen, and he had labyrinthitis, which when she put it together with the history and what we're seeing, it was really, really obvious and really, really easy to treat. But yeah, there could be loads of things. Like Ramsay-Hunt syndrome, I'm sure you've heard of that. That was up there as a differential. You'd want to exclude things like a space-occupying lesion. They can present with just things like vomiting and not feeling very well, and not very specific at all.
How did you treat it? If you
It's just antibiotics.
I don't know.
I can't remember now. Yeah, you can look that one up.
You'd look it up. You consult trust guidelines on management of labyrinthitis.
Just what he said. So yeah, some previous leads, Neuro OSCEs. I'm sure there's like a list that circulates around every year of about the past 10 years of OSCE stations, which I'm sure if you haven't got your hands on already, I'd definitely thoroughly recommend that you do. They reuse the stations year on year. So examining cranial nerves 3, 4 and 6 and performing the fundoscopy to identify the words. I'm sure you've seen those that have come up before, and you get them normally at Bradford. They get you to look in the eyeballs, they're like golf balls, and look at the eyes and things. It's a really, really easy one. You'd absolutely smash it if it came up.
Like we said, peripheral nerve examination. They tend to be quite sneaky, and they'll just say do some of the, like either just do sensation and coordination, or they might not get you to do all of it. So just read the station carefully, and it's also pretty easy for people to put on that they've got peripheral neuropathy. They'll just say, oh no, I can't feel that anymore.
And like we mentioned, ours last year was a video of Parkinsonism. It just threw everybody, really, to be honest. It seemed a bit too straightforward to be true, but it was the kind of finer detail that you just need to be a bit more clued up on. But everybody passed it, I think. So.
And quite a savage one, I think. Because I thought this was a 4th year station, but this came up in finals a few years ago, was epilepsy counselling, so somebody just diagnosed with epilepsy. So like everyone says finals are straightforward, but occasionally they'll throw something in which you're not expecting. But as long as you've been on the wards and you've know something about epilepsy and something about Parkinson's, this is really common stuff. So they expect you to be able to piece something together.
Okay, so that's kind of sums up the majority of what we've got to talk about. If you're ready, do you want to get some pens and paper?
Ooh, should we do questions first?
Yeah.
Anyone want to ask anything before we do the slideshow about neurology and OSCEs? OSCEs in general. I'm sure everyone asks you this after their lecture.
Is optic neuritis usually unilateral, bilateral?
I think in MS it's usually unilateral, but I'm not entirely sure.
Is it painful or?
It can be painless. I know for sure it can be painless. I don't know if it's usually painful. But it's always good to ask. Do you have any pain? Anything else? Any burning questions? Jolly good?
Yeah. Oh. Is everyone ready? Astounding, yes. So we'll get going. So yeah, 40 seconds per slide. There's a couple of seconds on each slide. Some of them might be a bit challenging. Don't worry if you don't get them right. You've got loads of time to finals. So ready, off you go.
Can't see the legs.
It's just better than my...
Oh no. That could happen in the actual slideshow or something like that. We'll tell you about that afterwards.
Cool. Okay, pens down. So we'll just go through the answers. So, one, can anyone tell me what nerve's affected? Radial nerve, yeah. So what's the sign that you're seeing there? Wrist drop, excellent. And how is it commonly injured? This is a bit of a... Very good, yeah, Saturday night palsy. So it's when someone's got really, really drunk and they've fallen asleep, arm hanging over the chair, and they're dead weight on it. When they lift it up, they can't feel it. So yeah, very good. Point for each of those if you got it right.
Okay, so there are actually two signs shown here. Very good. Inverted champagne bottle leg. And what's the other sign? Charcot joint, yeah. And then what's the diagnosis?
I can hear people saying it a bit louder.
It is Charcot-Marie tooth disease. Very good.
So what signs do you see in Charcot-Marie tooth in general? Like if someone says Charcot-Marie tooth and you have to describe it, how would you describe it?
So it's generally what she's presenting with in this. So it's common presenting in young adults, and they have a foot drop's quite common, and just wasting of the muscles in the lower leg. And the champagne bottle is a classical sign for it. Like you said, it's just something to come up in the slideshow. I don't think it would come in any other way.
Does anybody, for a bonus point, does anybody know what else you get champagne bottle legs in? Yeah, chronic venous insufficiency.
Okay, so what nerves affected for this patient? Anybody? Which nerve? Third, yeah. Okay, and what could be causing this? Pardon?
Yes.
Yeah.
Yeah.
Any others?
Just go through your surgical sieve, infection, vasculitis.
Yeah, space planning lesion. Classic. So yes, this patient's got ptosis, their pupils pointing down and outwards, and they've got a dilated pupil as well, so they're the three things that you commonly get with cranial nerve 3 palsy.
In the slideshow, questions where there might be quite a range of answers.
Yeah.
Is quite a range of answers, as it were.
Yeah. I don't know if you know how it's marked with Richard Fuller just has a glass of wine and has a bit of a laugh, really. He just sits there and gets smashed, and it's his discretion, really. I'm sure he's got some answers that he will only allow, but it's not like they get sent off to an exam board or anything. So if you put something that's sensible and you could easily justify it, I don't see why you wouldn't be able to get the mark.
Okay, so I just like to point out that I went through the whole 5th year refusing to learn fundoscopy because I really didn't think it was worth it. And then it came up in the slideshow, but I still passed. So if you really can't face it like I couldn't, then you don't have to learn it. But it is quite a useful skill to have, obviously. So what does this show? It is papilledema, very good. And what is the most common cause of papilledema? Yep, very good.
Okay, so what's the name of this condition? Yeah, very good. Bell's palsy and what nerves affected? Yeah, so cranial nerve 7.
Does anybody know, for an extra bonus point as well, does anybody know where it's commonly inflamed? You know you're saying it. It's where what does it travel through? The stylomastoid foramen.
So another one of those papers.
Oh god, yeah. So what's shown here? Yeah, what's this showing? We've got one vote for proliferative. We've got another vote for pre-proliferative. This is why I just never bothered learning it, because it's just, you can never see this anyway. This is actually background diabetic retinopathy. So you've got some dot and blot hemorrhages, allegedly, and some hard exudates can be seen around the left upper quadrant.
Okay, has everyone got that? And then, oh, where's the last one gone?
What's after that?
It's not that, look. Oh yeah. So just to make it dead easy for you to learn, we've got some slides. We're not going to read through them. You can do that at your own leisure. But the classifications of diabetic retinopathy and hypertensive retinopathy, that's pretty much all we need to learn, really. Just paraphrasing that.
If that.
Yeah. And then last one. So where's the lesion and what's the type of vision called for A? So which number or... So yeah, number 3. So on the optic tract, and what kind of vision would this patient have? So, yeah, so left-sided, homonymous, myopia, if I say those words. And for B, where would be the lesion? Yeah, number 1, so along the optic nerve. And what's that kind of vision called? Yeah, so binocular blindness, great. This actually came up, I think, as an EMQ one year, which would be an absolute godsend if you got this. So
if you know it, if you don't know it, it's a nightmare.
Yeah, I think it'd be a godsend. So yeah, any questions about OSCE or slideshow or anything else that you feel that we've not covered that you just want to ask?
Is the slideshow the next bit? So I'm confused.
No, it's in like the Foreman clusters.
Oh, okay, like 4.
Yeah.
And it's normally like an M40 where you have to like cancel out ABCD.
No. The slideshow in 5th year is like written out short answers.
So guys, look, thanks for staying away. If we can do it, so can you. It's really not that bad. I'm sure that you'll turn up to all the CAMAS lecture finals lectures, is what I'm saying, and they're really, really useful. So try and make the most of them.
Yeah. And best of luck. We'll see you on the other side.
If you could all fill out a feedback form, it'd be really good, not just for us, but to make sure that we improve these lectures for you. And the first ones to hand them back in get sweet. So, sorry. Is there anyone else?
Yeah.
So, no. Yeah,
Thank you very much.